from ICT International. I'm trying to contextualize my question, in relevance to the theme of the panel, Ayushman Bharat, and also coming from the climate change lens. Given that, climate change will exacerbate, the risks which are, primarily in the domain of primary and secondary health care. I wanted to, pose a question to, the entire panel. My concern is to strengthen healthcare, primary healthcare. So, how would you respond if I asked, how can you strengthen primary healthcare delivery services, quality services? Can you strengthen primary healthcare quality services through including primary healthcare in Ayushman Bharat by linking, the doctors in the rural areas to payment, performance-based, incentive-based payments?
This is to Professor Malani. There's something about market equilibrium here I'm missing. That is, if people could have gone to the public hospitals in the first place, which was one of the reasons why utilization increase wasn't so high, why didn't they also think of that as financial protection? That is, what credibility did the program give them that the existence of the public alternative didn't give them, since it affects the quantity but not the financial attitude? The second, related to that is there any information on what this might have done to prices in private facilities?
Question is to Anup. Anup, did you at all look at what the impact was of the insurance program of people who were not covered? Because the fear is that with Ayushman Bharat, some people will come under coverage and people who were utilizing those facilities earlier may get pushed out. So you may have adverse health consequences for a certain group of people.
And my question is for Tarun. Tarun, that was a wonderful presentation. The question I have is those 3.3 million hospitalization or procedures that you cite. 3.3 million divided by 8 is 400,000 per year. If you assume very generously, given Andhra Pradesh's population of 80 million, the 60 million are covered by Arogyasri, that would mean a 0.75% hospital use. But we know that the hospital use rates among richer groups are much higher. So do you really believe that if you had a very generous scheme, it would remain at 0.75, and therefore would like to rechange your assessment of rupees 200 per person as being an appropriate cost?
My question is to the entire panel when we talk about Ayushman Bharat in total, then we highlight about the numbers that this much patients are availing treatment at private hospitals, and there is an uproar about this thing. But we never boost about the augmented facilities and services and people availing them at public health facilities. So is it killing public health system slowly?
Healthcare. So there is a variety of experience in this area, including Government of India itself attempting to pay for performance in primary healthcare. What is the global evidence and what is being talked about that individual-based incentive rarely function or rarely deliver outcome. So the only option left is a team-based incentive that have shown some impact. But the challenge in setting like India is that we work in a setup or system where there is a limited data available on which you can pay for their performance. So it will be very challenging, but it's something worth exploring, mainly team-based incentive. But it's really required some capacity building, some data strengthening before you can arrive at what formula in a setup where health worker keep complaining they are already underpaid. So what proportion should be their fixed salary and what proportion should be their incentive-based salary? So those are the challenges. So that's a separate debate. Summarize, yeah, it is possible, but with its own challenges. I quickly want to reflect upon, since you raised the issue of climate change and how health system can be prepared. I think the new discourse, and which is again academic, but academic discourse reaches a point where they become operational also. That till now the program were in India or many countries were focusing upon vertical oriented or disease focus, that okay, this program will deliver this thing. And if we talk in terms of climate change, that will not be the appropriate approach. Rather, the new approach which is being discussed is that what services are needed at that level, be it primary, secondary, or tertiary, and who can deliver those. So that's another important discussion which should happen separately. Thank you.
Professor Malani, would you like to answer the other questions?
Sure. So thank you very much for those two questions. Let me address the first question, which is, or I don't know what the order is, but let me address the question about the impact on public facilities versus private facilities. I think public facilities are already an existing safety net. RSBY in some sense just expanded the safety net to allow you to go to private facilities. If public was an adequate safety net, then you're not going to see, that may explain exactly why there was an increase in utilization, so you're correct there. Now in theory it's possible that what happened is RSBY provided demand side incentive that would increase the amount of private facilities there are. I think there's value to increasing private facilities. In theory it's possible. However, we don't have great evidence on that actually occurring, and the reason is we don't have a great census of beds or hospitals, and I think that's something that we ought to do, and if we're going to do something like Ayushman Bharat and properly funded, then it's going to be the case that you could have a big impact on the private sector in terms of private facilities, but we need to measure that, and we don't have the data to do that. One limitation I think that's important is that prices are low for Ayushman Bharat now, and nor do they reflect differences in the cost of production in rural areas versus urban areas. Unless you do that, what you'll see is mainly effect on private facilities in rural areas, but not in urban areas. The second question is about whether or not there's spillovers. We think that when we started the study, we thought that was a real big concern, that if you provided formal insurance for some people, you could crowd out informal insurance for uninsured people or affect the credit markets for them. And we actually designed our study to address that very question. So we varied the fraction of people that got insurance across different villages, and we randomized in that in order to get the impacts, those spillover estimates. However, we found that there were no spillovers that we could find from the people that were insured to the people that were uninsured. To some extent, that's quite reassuring in the sense that there could have been negative spillovers, and we don't observe that. Let me stop there so other people can comment.
So to come back to the last question, which I found really interesting, and this is interesting especially after the slide that was put forward by Dr. Narayana, which showed that there are very few private hospitals which has actually got themselves empaneled in Bihar. So as a result, what might happen that all these patients will be pushed towards the public health facilities, and we all know there are multiple evidences that they are already overburdened. So they will be handling huge number of patients, and that might even further deteriorate the quality of the tertiary care that they are providing.